Well, hello, I'm David Legge. In this presentation, I'll be talking about the history of WHO in the context of the changing preoccupations of global health policy. I hope you find it useful. The prehistory of WHO is written in the story of the international sanitary conferences and conventions. On this slide, I've listed on the left-hand side the sequence of these various conferences since 1348. And on the right-hand side, I've listed some of the parallel geopolitical issues which were taking place in the 19th century at the time that the first International Sanitary Conference took place. Quarantine appears to have started in Venice with the plague in 1348, and we believe that the ships coming into Venice were required to wait 40 days outside the port, corresponding to the 40 days and 40 nights that Jesus spent in the wilderness. By the 19th century, the big issue was still plague, but also cholera, which was identified as Asiatic cholera, and seen to be coming from, in particular, India. There was a big epidemic from 1831 and then again in 1848, and this overshadowed the first International Sanitary Conference held in Paris in 1851. This was convened by the French Ministry of Agriculture and Trade, and each country participating, mainly European countries, had both doctors and diplomats. The sanitary regulations which were adopted at this time were never ratified. The debate was fierce around whether quarantine would be effective in relation to cholera. This is a period when the germ theory of disease was in its infancy, and the argument, of course, was that quarantining maritime boundaries and borders wouldn't solve the problem of land borders. There were further sanitary conferences in 1859, 1874, and so forth, right through to 1894. And the main themes of discussion were still the defence of Europe against exotic pestilence, the removal of hygienic hindrances to trade and commerce, and the emerging principle of disease notification. Okay, so during this 19th century, we need to identify some of the parallel things which are happening. The revolutions in Europe of 1848, the Prussian War of 1870, the Paris Commune 1871. The point I'm making essentially is an emergent competitive imperialism based in Europe. British imperialism highlighted, epitomised by the Raj in India from 1800, 1850 onwards. The Opium Wars against China from 1832 and then again from 1856. The Opium Wars are an interesting case of war to achieve free trade. In this case, it was to force free trade in opium on the Chinese people. Britain at this stage was suffering from the rapid urbanisation associated with the repeal of the Corn Laws. This had the effect of driving thousands of farmers off their land, and with that, the rising of free trade, the import of cheaper corn, with that came the massive emigrations as part of British settler colonisation. French colonisation of Algeria from 1830, French colonisation of Indochina from 1870, the West African colonies from 1880, and then again in the Western Hemisphere, the extension of the USA. So the the point I'm making essentially is that the international sanitary conferences were held largely among Europeans. They were largely about protecting Europe from from Asia, or the what we now might call the developing world, and that they took place in the midst of a rising competitive imperialism. On the bottom of the right-hand column, I've just listed a few dates regarding the emergence of germ theory. John Snow demonstrated that at least the water supply had something to do with the spread of cholera. Joseph Lister demonstrated the principle of hygiene and antiseptic surgical technique in the 1870s, and Robert Koch finally demonstrated the role of germs in tuberculosis. It was increasingly evident that the periodic conference model needed a permanent secretariat. And in 1907, the Office International de Hygiene Publique, which became known as the Paris Office for reasons I'll explain shortly, was established. And with a permanent committee, a president and a secretary general. Some of the issues upon which the OIHP focused in the early years were largely on communicable disease, cholera, plague and yellow fever. And a great achievement was in 1999, promoting methods for preventing rats from accessing ships, the compulsory notification of TB, leprosy and yellow fever, and the monitoring of drinking water. However, within a few years, the OIHP was held up through the Great War, or the First World War, from 1914 to 1918, which ended with the Treaty of Versailles, and the next sanitary convention took place in 1926, when smallpox and typhus were added to the list of quarantinable diseases. Meanwhile, the OIHP continued, but from 1919 the League of Nations was established, and from 1920 there was a proposal for an international health organisation associated with the League of Nations. And 1922 a provisional health committee was established for this international health organisation, with funding from Rockefeller, which went from 22 to 34. There was a period of intense competition between what became known as the Geneva Office, which was the International Health Organization of the League of Nations, and the OIHP in Paris. OIHP was not happy to just simply hand over their international role to the International Health Organization, and in the end the OIHP was positioned as the General Advisory Committee to the Health Organization of the League. Then, of course, we have 1929, the Great Depression, 1933, the Third Reich, and the progress in terms of international or global health governance is suspended while we have the Second World War. The work program of the League of Nations Health Organization bears really interesting similarities to the continuing work program of WHO today, with a role in quarantining disease, in standardizing anti-diphtheria serum, providing advice about venereal disease in C persons, the control of narcotic drugs, publishing notifications, so which is still a major role for WHO. The Malaria Commission of 1923, the preparation of the standard pharmacopoeias and each edition of the standard pharmacopoeia, work on nutrition and public health surveillance and control. These are still functions of WHO. Meanwhile, in the Americas, similar developments were taking place, which would have quite important significance. The International Sanitary Bureau was established in 1902, when this became the Pan American Sanitary Bureau from 1923. The Rockefeller Foundation was heavily involved in a lot of these things. As I mentioned, they supported the League of Nations Health Organization, and from 1909, the Rockefeller Sanitary Commission on the Eradication of Hookworm was operating. From 1913, the International Health Board of the Rockefeller Foundation was established. And the other major landmark of this period is the Panama Canal, which was built in two phases. The first phase was not a success. That's from 1881 to 1890. And the second phase, from 1902 to 1914, was successful in part because of the control of the mosquito. On the right-hand side of the slide, I've listed four diseases which are of really great significance in terms of the political economy of public health. The mosquito, the Plasmodium, malaria, the parasite was identified from 1880, the role of the mosquito from 1881, and of course malaria was a major problem in the building of the Panama Canal. Likewise, yellow fever, which was first the cause of which was attributed to the mosquito by the Cuban Carlos Finlay from 1881, and then Walter Reed in the 1890s continued to work on controlling the mosquito as part of building the Panama Canal. The pellagra, which was a major burden on the cotton industry in the American South, was discovered to be a consequence of vitamin deficiency by Joseph Goldberger from 1926. And hookworm was another major burden on the cotton industry of the South. The life cycle of the worm was demonstrated in 1899 and eradication from 1909 to 1915. So these are all conditions which were of huge economic importance, and the effort which was put into controlling them reflected this. WHO was established as a consequence of the establishment of the UN in 1945, and at the UN establishment in 1945, Brazil and China called for an international health organization. A preparatory committee was established which operated from 46 to 49, and an interim commission was appointed. The WHO, there was an international conference, health conference in New York in 1946, and among the other things that the interim commission undertook was the WHO constitution. And I make 3 points about this constitution. First of all, the inspiring definition of health at the beginning of the constitution. Health is not just the absence of disease, but social, physical, mental well-being. The second is the regionalisation of the WHO. WHO stands out among other intergovernmental organisations for its decentralisation, for its 6 regional directorates. And so there are 3 levels, or 3 sets of governing bodies of WHO: the Assembly, the Executive Board, and the regional committees. And the third thing about the WHO Constitution are the treaty-making powers of Clause 19 and 21, which allow for making of treaties and making of regulations. This is unusual among intergovernmental organisations and has a very great significance in terms of the potential role WHO in global public health. I'd like to introduce now Dr. Brock Chisholm, who was the Executive Secretary of the Interim Commission for the WHO, who was the main coordinator of the establishment process, including the development of the Constitution. And the Commission oversaw the transfer of functions from the previous health organisations and the integration of regional organisations, including PAHO, into the new WHO. And so in 1948, WHO is established, and Brock Chisholm is appointed the first Director General, and the first World Health Assembly is convened. On this slide, we've got the organogram of the first organisational structure of WHO, that is to say, the Geneva Secretariat. Obviously, the organisational structures of the regional secretariats were different, although they probably corresponded broadly to this. The separation of advisory services from what are called central technical services is worth noting, because in a sense this characterises the difference between what is now called the normative functions. If you read about WHO, you find a lot of people talking about the normative functions of WHO as distinct from, and this is generally not stated, WHO's political engagements in terms of policy making. And so in the terms of this organogram, advisory services which involve policy formation would be frowned upon in some degree by the larger donor members who believe that WHO should restrict itself to the so-called central technical services. So here's a picture of Dr. Brock Chisholm, the first Director General of WHO, appointed in 1948. Retired from office in 1953. He was the one of only a couple of DGs who only had one term, and it's probably not an accident that he only had one term. Brock Chisholm was a military hero, a Canadian psychiatrist, a military hero in World War I. He's a very interesting person, an iconoclast of significant status. Anti-nationalism, anti-religion, anti-Santa Claus, against moral dogma and against nuclear weapons. He had been Chief of Army Medical Services and then became Deputy Minister for Health from 1944 to 1946. Heavily involved in the development of WHO from 1946 to 48, and then the Director General from 48 to 53. It has been suggested, perhaps unkindly, that the reason the Canadians supported him as Director General of WHO was to keep him out of Ottawa, because his unusual personal opinions caught a lot of flack in the media. Okay, so Dr. Brock Chisholm had first of all to negotiate the WHO budget. And as is the case today, the rich countries were quite reluctant to stump up a great deal of money for the budget, and so it was quite a trouble negotiating the formula for the assessed contributions, and not made easier by the US reluctance to join in the first place. One of the big issues he faced was the Pan American Sanitary Convention and the Pan American Health Sanitary Organization, which were very unsure as to whether they wanted to join WHO or not. And as I've said, they extracted quite a high price in terms of the highly regionalized structure that we have inherited as a price for their joining. Excuse me. The first Israel-Palestine war took place in 1947, so that war, and then with that came the new United Nations Relief and Works Agency and WHO's relationship with the Palestine issues. The First Indo-Chinese War, the war of the French against the Vietnamese and the Laotians and Cambodians from 1948, 47, and the continued guerrilla warfare from North Africa, particularly Algeria, against French imperialism. One of the big issues for Brock Chisholm was the Soviet withdrawal from WHO from 1949 to 1956. Not just the Soviet withdrawal, but all of the USSR and its allies withdrew during this time. Two issues which were particularly problematic for Chisholm occurred during this time. One was the struggle over population policy in the Vatican. The Vatican was much stronger then, that is, within WHO than it is now, probably, and was determined to ensure that WHO had played no part in family planning or contraceptive advice or anything of that sort. And this was a challenge to Chisholm, who of course would have had very different views. The other issue was the role of WHO in providing advice regarding health systems as opposed to technical matters. And there was one document that was produced in 1953 under Chisholm's leadership, which made some brief reference to health insurance. And it is astonishing to read in Farley's report. Farley's written this excellent book about Chisholm, that the US came down very hard on the WHO Secretariat, but for having implied that insurance might be a good idea. The position was, of course, that first of all, this was a period in the middle of the Cold War. Secondly, it's the period in the middle of McCarthyism within the US. Thirdly, there's only relatively few developing countries present in WHO at this time, so it is still largely dominated by the rich countries. And fourthly, WHO was allowed to refer to basic health services, but it's not all that clear what that was supposed to mean. But there was an intense debate going on in the US at this time about health insurance, and it was seen as being akin to communism and socialized medicine. And anyway, this was part of the reason why Chisholm got into trouble for mentioning health insurance. The next Director General was Dr. Marcelino Candal, who was a Brazilian malariologist who was there for 20 years, 1953 to 1973. Dr. Candal had been in the Brazilian Public Health Service for many years, 1934 to 1950. He joined WHO in 1950 and was involved heavily in onchocerciasis control before his elevation to DG. His interests included malaria, parasitology, biostatistics. He contributed to the development of the WHO role in research, and this was a period when there were huge debates around malaria, either eradication or control, and we'll come to what that means in due course, and smallpox, and of course the Congo crisis of 1960 to 66. During Dr. Candal's period, in the left-hand column, we've indicated some of the major issues which were being considered by WHO. Malaria is an interesting one because malaria eradication was put very firmly onto the WHO agenda by the US. Some people say the US enthusiasm for malaria eradication was in part related to its military aspirations. It's continuing to send military to send troops to the outer reaches of its empire. But in due course, it became very clear that the malaria was not going to be eradicated and that the challenge needed to be one of control. The initial strategy for eradication was based heavily on DDT, the major insecticide, which was finally banned after concern regarding its ecological impact. Malaria is still a huge problem, but WHO has stepped back from the goal of eradication back to a goal of control. Nonetheless, as we shall see, it is still treated broadly as a vertical disease control program, and the power of a comprehensive primary healthcare approach to malaria control has not yet been widely implemented. A lot of these other topics are fairly familiar to us. Obviously, radiation was a big issue in the 1950s. Pharmaceutical standards and statistics and publications all come up again and again and again, as of course quarantine remains on the agenda. So the period from in 1953, the period that Kandau inherited the Director Generalship, is shaped by the events down the right-hand side of this slide. Victory over the Axis powers in Europe on the 8th of May 1945, the dropping of the bomb on Hiroshima and Nagasaki in August 1945, and then the beginning of the rebuilding, in particular the rebuilding of Europe using the Marshall Plan. The Marshall Plan was a major funding program sponsored through the US, whereby both credits and grants were made available for redevelopment in Europe. This is also the period of the Cold War, which let's call that 1948 through to 1989. And in the US, it was the period of McCarthyism, which was a sort of political madness about chasing down communists, which was particularly focused on Joe McCarthy, a senator, and J. Edgar Hoover, the FBI director at the time. The Korean War took place from 1950 to 1953, which were added obviously to the freezing of the Cold War. And as I've mentioned, the Eastern European walkout from WHO didn't make things easier for either Chisholm or Kandau. And as I've mentioned, the first Indo-Chinese War of 1947 to 54, and then the Vietnam War run directly by the US from 1955 to 1975, provided one of the major features then of Kandau's Director Generalship. Dr. Kandau handed over directorship to Dr. Halfdan Mahler, who was a 15-year term Director General, and in many people, one of the most outstanding, for many people's view, one of the more outstanding of the Directors General. Dr. Mahler was born in Denmark. His father was a Baptist preacher, and Dr. Mahler was always a bit of a preacher himself. He graduated MD at the University of Copenhagen, was a tuberculosis specialist in the early part of his career, first of all in Ecuador and then in India. Then from 1962 to 69, he was head of tuberculosis at the headquarters of WHO in Geneva. He then moved from there to be Director for Program Systems Analysis, and subsequently Assistant Director General. Um, of particular importance during this time is the publication in 1973 on organisational study on methods for promoting the development of basic health services. You can see this term basic health services is there, but this is a period when the developing countries are complaining more and more loudly that WHO is not providing them with the guidance they need to develop health systems. This is a period when the world attention is being drawn, first of all, to the from in around the 50s to the Soviet health system and to the British NHS, and then in the 60s and 70s to the Chinese healthcare system. And so the developing countries were saying, where is WHO in all this? Why aren't you providing support? So this was something that Dr. Mahler was involved in from the early 1970s. He became Director General in 1973, and in 1975 was exploring alternative approaches to meeting basic health needs. This was a publication by both UNICEF and WHO. And that project looked at successful primary healthcare practice in various countries. In particular, Mahler was listening to the senior people involved in the Christian Medical Commission, which was a subunit of the World Council of Churches, and which represented many of the faith-based health systems in developing countries, and which was pointing out the value of programs such as the early primary healthcare project in Solo in Indonesia, the Jamkhed project in India, and the role of health promotores in Guatemala. And these three instances, which are documented in a book published by Ken Newell called Health by the People, published in 1975 by WHO, it's on the WHO website, was very influential in the shaping of the Alma-Ata Declaration. We'll come back to the development of the Alma-Ata Declaration because it's quite a good story. Dr. Mahler coined the slogan "Health for All" by the year 2000 in the year 1976, but it was not to be. The year 2000 has come and gone, and we still don't have health for all. After his role as Director General, he took on a role as the Secretary General of the International Planned Parenthood Federation from 1988 to 1999. So what was the context that he took office in 1973? The context was the continuing Cold War, although the Soviet bloc had returned to WHO in 1956. The Cold War continued, focused very much on up till that time on the Vietnam War, although that was coming to an end. The developing countries were much more confident, more aggressive, more confident of the possibility of there being a non-aligned movement, the non-aligned movement associated with the group of 77 developing countries, non-aligned countries at the WHO, at the UN, and the significance of the new international economic order, which was adopted by the UN General Assembly in 1974. This was a call for a global economic policy paradigm which would allow space for developing countries to provide some level of protection for local industry, for developing so-called infant industries. And this was strongly influenced by the so-called dependency school of development economics based in Latin America. However, even as the new international economic order was starting to gain traction as a slogan for the developing countries, the long boom of high growth rates and relatively high growth rates from 1945 onwards um, started to come to an end in the early 1970s, late 1960s. And what we will see is the emergence of stagflation, and then the debt crisis, and then high interest rates in the 1980s, and the so-called lost decade of the 1980s, which we'll come to. Among the strategic confusions facing WHO were the problem of coordination, both within the Geneva Secretariat and between the different levels of WHO's secretariat work. That's to say, the country offices, the regional offices, and Geneva. Questions about how WHO should work. Should the emphasis be on technical advice from Geneva, or in Dr. Mahler's view, he wanted to get his experts out into countries to assist with country advice. And I think this is an issue which has continued to plague WHO ever since. So on this slide, we've listed five broad areas, six broad areas where WHO was active during this early period of Dr. Mahler's Director Generalship. Under the heading of health systems, there was a continuing push to move from a focus on diseases to a focus on basic services, and then from basic services to primary health care. Part of the primary healthcare model was so-called appropriate workforce structures, and that in these days was referred to as auxiliaries. So there was the idea of moving from doctors and hospitals in the big cities to community health centres and auxiliaries in the rural areas. Under the communicable disease, as I've said, the aspiration to eradicate malaria had become a malaria control program, but smallpox had come onto the agenda. The politics of that involved the return of the Soviet bloc. When the Soviet bloc returned, they seemed to they wanted to push some of their policy ideas, one of which was their model of health systems, the use of the polyclinic and their particular workforce model, but also smallpox eradication. And so smallpox was very different from malaria in the sense that it was in fact open to being eradicated because of the possibility of because patients are identified very quickly when they've got the disease, and it was possible to vaccinate so-called around each outbreak, to do a circle of vaccination around the outbreak and prevent it spreading and gradually wipe the disease out, which is what was achieved with the last case declared in 1977. The expanded program in immunisation was an important vehicle, and vector control was also a major issue for communicable disease. In terms of non-communicable disease, there was increasing research. Radiation exposure was an issue. Pharmaceuticals was again on the agenda. The manufacturing standards and the standards of good manufacturing practice was a major issue. The essential drug list was introduced in the late 1970s, early 1980s. This was intensely fought over because the drug companies didn't like it. Dr. Mahler was asked in the executive board on one occasion, what are you doing about we are, by one of the developing countries, saying we are being pressured by the drug companies to put all sorts of drugs on in our pharmacopoeia, in our clinics, and the essential drug list was an attempt to protect small countries from aggressive marketing by the drug companies. Health statistics and information again was a growing important role, and again this represents the so-called one of the normative functions of WHO as opposed to its much more controversial advisory functions or health policy functions. This is a picture of the Alma-Ata Conference, mainly men, mainly in suits, many of them smoking, and a picture of Dr. Marler at the bottom right with Teddy Kennedy on his right. On this slide I've listed some landmarks with respect to health systems policy at WHO. I've mentioned that from 1948 through to 1970, the focus was on basic services and the training of health professionals, particularly in the early days doctors, but later auxiliaries. 1978 is the Alma-Ata Declaration, but within a very short time, the aspiration of comprehensive primary health care was reduced to selective primary health care, which the view was taken that comprehensive primary health care would be too expensive, couldn't be afforded. Therefore, UNICEF took off on their own. UNICEF had previously been a partner of WHO in Alma-Ata, but with the new Director General there, they took off on their own to push what was called the Child Survival Revolution, which included the principle of GOBI, which stands for growth monitoring, oral rehydration, breastfeeding, and immunisation. Then there's a period of disease-focused development in WHO. First of all, the diarrheal disease control program, and then the acute respiratory illness program. And there was, even in the early stages, some criticism about the disease focus, and there was a recognised need to somehow bring these together. Come back to that. The 1986 sees the Global Program on AIDS established within WHO. Although if you jump ahead to 1996, 10 years later, WHO is stripped of a lot of its functions in relation to AIDS with the establishment of UNAIDS, and there's a long story about this, but it would appear that Dr. Nakajima, who was the Director General from 88 to 98, was not very helpful in developing the AIDS program in the late 1980s. And Jonathan Mann, who was regarded as a very inspirational leader in AIDS, was first of all involved in the global program on AIDS, but he left that, but came back to UNAIDS when that was established. This list of events is chronological, but it involves, I've tried to weave in some of the other things which are happening at the time. And Adjustment with the Human Face is a very important document published through UNICEF, which contained quite stringent criticism of the structural adjustment programs being imposed on developing countries during the debt crisis. So the debt crisis, I'll remind you, starts in 1973 with the oil price rise, which led to a whole lot of cash flowing to the oil producing countries, many of whom didn't have anything to do with it, so they put the money in the bank. The bank went out lending it to whoever would pay, whoever would borrow, and because at that stage the interest rate was being offered was well below that of the inflation rate, countries were actually being paid to borrow money from the American and European banks. However, in 1981, at the end of the long boom, at the beginning of the stagflation period, the US and British leaders of the time, that's Reagan and Thatcher, adopted a monetarist policy which involved high interest rates. This is the debt trap being sprung. The developing countries now have huge debts, and the interest rates have now gone, in the early 1980s, have gone up. And as the countries find themselves unable to repay their debts, they're forced to turn to the IMF, and the IMF imposes really stringent structural adjustment packages on these developing countries. So this is the context of the adjustment with a human face. The World Bank steps in 1993 to take some of the pressure off the IMF and produces a very glossy, lovely report which demonstrates that you can have health and structural adjustment if you follow the World Bank's advice, which is pretty miserable. Now, getting back to this issue of the diarrheal disease control program and the acute respiratory illness program, 1995 we tried to pull these together in what's called the Integrated Management of Childhood Illness Initiative, trying to find ways of simply presenting strategies for managing both diarrhea and acute respiratory illness in infants and children that can be adopted by auxiliaries, that doesn't require intensive medical workforce. And I suppose I'm putting it here partly because it was a very important initiative, but partly because it illustrates the continuing balance which has to be struck within WHO between health systems policies and disease-focused policies. And of course, the same thing holds in 1996 with UN AIDS and the advent of highly active antiretroviral treatments, the antiretroviral drugs, which led to the treatment action campaign from 1997 to 2001, that was in South Africa, and a huge global revulsion against the claimed right by the drug companies to be able to set their prices for the newly available ARVs at whatever level gave them the greatest profit, without regard to the access to medicines for poorer people. So 2002 through to the early 2000s is the period when, following the WHO's Commission on Macroeconomics and Health, there's this massive increase in development assistance for health, in particular for vertical disease-focused programs, often run by the various public-private partnerships or global health initiatives. So this is the period of vertical programming, and by the end of that first decade, there's increasing criticism of vertical programming because of the fragmenting impact it has on healthcare, the internal brain drain that it produces, and the burden of reporting, the huge burden of reporting that that small governments are faced with. On the right-hand side of the slide, I've summarised then the Directors General, right through from Chisholm through to Margaret Chan, who's the present DG, all of whom have played a role in this long story of the evolution of health systems policy, and have played a role in the politics around that as well. And we may have time to discuss that later. Okay, so I've talked a little bit about the debt crisis. Let's go through this once more, but perhaps briefly. 1973, the Organisation of Petroleum Exporting Countries imposes quite a stiff hike in the price of oil, partly because they were compensating for inflation. They felt they were losing the value of their oil through inflation, but partly because of the the particular issues taking place in Palestine at that time. So from the period from 1973 to 1980, there are loan salesmen from the bank on the loose throughout the developing countries, offering loans at negative interest rates. That's to say, the interest rates were lower than the rate of inflation. And from 1981, in order to control the stagflation of the 1970s, the end of the long boom, the dramatic increase in interest rates, which led many countries to face huge increasing debt burden, and were forced to turn to the IMF for conditional assistance under the so-called structural adjustment packages. These structural adjustment packages, commonly produced, required the countries to open their borders to cheaper imports, to turn their economies to export orientation, not to try and develop their own industries, to cut taxes, cut public spending on food subsidies, on health systems, on education. And in many countries, the 1980s were known as the lost decade because so many things went backwards. In terms of health systems, it is a period of disinvestment. From 1999, structural adjustment packages were replaced by poverty reduction strategy papers, or PRSPs, which in many ways continued the same model, except that the PRSPs had to be authored, at least notionally, by the countries themselves. And in 2005, there was, after a widespread civil society lobbying under the heading of debt relief and Jubilee 2000, there was some debt relief offered for highly indebted poor countries. And we'll discuss that a little bit more when we come to look at development assistance. So structural adjustment included cuts in public spending, removal of price controls, freezing of wages, emphasis on production for export, trade liberalisation, incentives for foreign investors, and the privatisation of public sector services, and devaluation. Devaluation produces an increase in the price of imports. Loss of price controls means that prices go up. Cuts in public spending means the available resources for health, education, food goes down, and it is the lost decade. The role of the IMF is quite interesting. The IMF was established in 1944 in order to lend to countries, particularly the industrial countries, to prevent currency fluctuations due to short-term imbalances in trade flows. But from the 1950s to the 1980s, the private sector took on this short-term trade financing, and there was a risk that the IMF would have been a fund without a function. Fortunately for the IMF, the Third World Debt Crisis came along, and the IMF assumed its new role as lender of last resort and world economic policeman during the 1980s. Okay. So the impact of structural adjustments during the 1980s and beyond are, as you would expect, widening of inequalities, reduced purchasing power for the poor, downsizing of the public service, reduced support for subsistence agriculture, and in some cases economic growth, but not necessarily widely shared. I've mentioned the criticisms of structural adjustment and the adjustment with a human face, and these are referenced on this slide, which you can follow up. Okay, so at the end of the 1980s, Dr. Mahler, after 3 terms, stood down, and Dr. Nakajima from Japan was appointed Director General. He had 2 terms from 1988 to 1998. Dr. Nakajima inherited a the early years of AIDS. And he was a vaccinologist and was not particularly well prepared for taking on the challenge of AIDS. AIDS was identified in 1981, named in 82. The WHO Global Program on AIDS established from 1986 to 96, but from 96, because of the widespread dissatisfaction with Dr. Nakajima's leadership, or lack thereof, in relation to AIDS, the UN AIDS was formed. The logic of UN AIDS was also to recognise the importance of a multi-sectoral approach to this disease, which was far from restricted as just a medical problem. I've mentioned previously the Treatment Action Campaign from 1997 in South Africa, which was a landmark in terms of the interplay, the tension between the right of drug companies to set their price points wherever they get the best profit versus the issue of the right of access to drugs, and whether or not the WTO agreements, particularly the TRIPS agreement, protected the drug companies from being forced to get their prices down or not. The funding for AIDS started to accelerate in the late 1990s. This is partly because of the Treatment Action Campaign, and the UN General Assembly passed a major resolution in 2001. The Global Fund to fight AIDS, tuberculosis and malaria, with strong support from the Gates Foundation, started in 2002, PEPFAR in 2003. PEPFAR stands for the President's Emergency Plan for AIDS Relief. And this is right at the beginning of the Iraq-Afghanistan wars. And from Dr. Lee Jun-wook, who was the Director General from 2003 to 2006, established the 3x5 5 million people on AIDS within 3 years campaign from 2003. Yep. So Dr. Nakajima came in at the end of the lost decade and was by some accounts not very effectual, and perhaps for that reason was influential in the World Bank sort of taking over leadership in health policy in many respects. I've mentioned the World Bank's World Development Report of 1993 called Investing in Health, which was a major policy statement, but also signalled a dramatic increase in World Bank funding for health projects in developing countries. I've mentioned Dr. Jonathan Mann, who left WHO in 1990 because he wasn't able to get along with Nakajima, and joined UNAIDS from 1996. So this is a period, some of the things also happening during Nakajima's period is the 1992 WHO participates in a workshop with Big Pharma, the International Federation of Pharmaceutical Manufacturers and Associations, which adopted a definition of counterfeit, which has been problematic ever since, because it was deliberately designed to conflate the issue of trademark violations, which is what counterfeit is, with the problem of bad rubbish medicines, and to identify generic medicines as rubbish in order to protect the brand medicines from competition from generics. Um, this definition of counterfeit was adopted during the negotiation of the TRIPS agreement, and the TRIPS agreement doesn't use the term counterfeit to speak about rubbish medicines. Counterfeit under TRIPS is a reference to trademark violations. So during this period, Nakajima's inaction was a lot was going on, which was going to have a huge impact on global health, but WHO was not doing much about it. And I've mentioned here the conclusion of the Uruguay round of negotiations, which led to the establishment of WTO, the World Trade Organization, in 1994. WHO is in deep trouble during this period, continuing budget woes, increasing dependence on donors, and of course the donors are the rich countries, and so are the dependence on donors is also a huge constraint on what the member state countries in WHO are able to require of the organisation, because if the donors don't like it, it won't be funded. I've mentioned enough about investing in health. I think this was a major report in 1993 which introduced DALYs and DALYs per dollar, or dollars per DALY. The idea that you can construct a health system on the basis of identified commodified interventions. And the strategy was that by funding on an insurance basis, so funding individual services, individual interventions, a health system would be more cost effective. It hasn't proved to work. The World Bank, like the IMF, was an organisation lacking a function towards the end of the 1970s. The bank was established in 1944 to fund large-scale development projects, particularly in the developing world. But increasingly, from the 70s and 80s, private sector funding took over in terms of providing long-term capital for developed world projects, and the World Bank shifted its attention to developing countries. Initially as a provider of capital for, initially and still as a provider of capital for infrastructure projects, but from during the period of the 1980s, the lost decade, the structural adjustment, the bank became more and more spoke of itself as its project as abolishing world poverty, not just through major infrastructure projects, but also through telling countries how to run their health systems. And in the 1990s, it far surpassed WHO as a donor and probably also as a policy advisor on health. From the 1990s, the importance of trade agreements and investment agreements became increasingly clear for those to whom it had not been clear before. The World Trade Organization was established in 1995, and it brings in 23 new trade agreements. The three agreements which have particular significance for health would be the TRIPS agreement, with its impact on the cost of medicines, the agreement on agriculture, which legitimated a system whereby the US was allowed to export subsidized food, which has had a devastating effect on small farmers in many developing countries, and accelerated tariff reductions, which have made the development of local autonomous industry very, very much harder. The GATS agreement is the agreement on trade and services is another important agreement for health, although its main focus is finance and consulting and banking and so forth. The North American Free Trade Agreement, which linked the Canada, Mexico, and the US, was inked in the same year as the World Trade Organization was established. But the NAFTA, North American Free Trade Association, includes provisions which the US was not able to get through in the WTO agreements, the so-called WTO plus or TRIPS plus provisions, and includes things like investor protection, in particular investor state dispute settlement. In other words, ISDS, investor state dispute settlement, which allows investors to sue governments if they adopt policies which jeopardize the profits of those investors. The World Trade Organization has got a dispute settlement mechanism, but it is a country-to-country dispute settlement, not company to country. The Doha so-called development round was launched in 2001, but different people have very, very different views of what Doha was supposed to achieve. The developing countries thought it was going to be a round which facilitated economic development in poorer countries, low and middle income countries. The rich countries thought it was going to be an opportunity to further tighten the provision of the WTO agreements, in particular to bring in what had been excluded from the WTO in the earlier years. So the NAFTA agreement was the beginning of moving outside WTO because it became deadlocked from 2003. To move outside it and seek to negotiate, this is the US objective, to seek to negotiate regional or so-called plurilateral agreements, which would be finalised within a small group of consenting countries, but then pressure would be put on other countries to join them. So it's an alternative pathway, so-called forum shifting, an alternative pathway to moving to the WTO plus standards which were being sought. In 2012, excuse me, the Transatlantic Trade and Investment Partnership, or TTIP, was initiated. In 2008, the Trans-Pacific Partnership Agreement was initiated, and in 2013, the Trade and Services Agreement were initiated. These are the TPP and the TTIP are regional agreements which include all the chapters which correspond to the WTO agreements, but also include investment chapters and may include ISDS provisions. The Trade and Services Agreement is to make up for the fact that the renegotiation of the GATS agreement, the WTO General Agreement on Trade and Services, had deadlocked, and therefore, again, a small number of countries, of consenting countries, would negotiate a new agreement, which would then be forced on the rest of the world. That, at least, is the strategy. None of these agreements have yet been finalised, and they remain very political. This brings us to Dr. Gro Harlem Brundtland, the Director General of WHO from 1998 to 2003. Dr. Brundtland was a Norwegian politician. She trained originally as a physician, but she was active in social democrat politics in Norway, was Prime Minister 3 times from 1981, 1986 and 1990, and particularly well known for her role in chairing what became known as the Brundtland Commission from 1983 through to 1987, when it published. This was the World Commission set up by the United Nations, World Commission on Sustainable Development, on Environment and Development. And that led to the Rio Conference in 1992 on Sustainable Development and Agenda 21. So she was very much an international diplomat and activist when, in 1998, she succeeded Dr. Nakajima as Director General of WHO. Dr. Brundtland inherited a legacy from Dr. Nakajima, in particular the rise of the World Bank and in health policy, and the loss of standing of WHO in relation to UN AIDS, in relation to AIDS and antiretrovirals and so forth. And she also arrived in the middle of the treatment action campaign regarding the tension between the TRIPS agreement and access to medicines, which we've talked about. The other major civil society movement, which was relevant to this time, was Jubilee 2000, which was campaigning globally around debt forgiveness in the wake of the 1980s debt crisis, and even worse, the impact of structural adjustment. Jubilee 2000 had been focusing on the OECD countries, and in particular the G8. So some of the things that Dr. Brundtland was particularly well known for as Director General of WHO was her work on tobacco control, and in 2003, the last year of her Director Generalship, the Framework Convention on Tobacco Control was adopted. She was also instrumental in setting up the Jeffrey Sachs Commission on Macroeconomics and Health. And I've commented earlier that this commission was in some degree designed to gain some drive from sailing in the slipstream of the World Bank, and reworked some of the analysis and ideology of the World Bank's 1993 report, Investing in Health. The Macroeconomics and Health report argued strongly for increasing development assistance for health, and in the succeeding years, the Global Fund was established, PEPFAR was established, and the Gates Foundation dramatically increased its contribution to development assistance for health. The environment that I've depicted earlier of the late 90s and early 2000s was one of criticism of structural adjustment, and criticism of the damage which was done by structural adjustment, and criticism of the World Trade Organization, in particular around treatment access. And out of that came the debate over differential pricing, which Dr. Brundtland convened a meeting in May of 2001 to support differential pricing. But at the Doha meeting of the Ministerial Council in November 2001, it was made very clear that the flexibilities implied by the TRIPS agreement provided ample scope for countries to ensure that medicines would be affordable. So just a few more comments on the Commission on Macroeconomics and Health. As I've said, it was commissioned to assess the place of health in economic development, notably not to assess the place of economic development in health. It concluded that poverty carries a threat of violence and instability. It argued strongly for donor financing. It endorsed the PRSP process as a mechanism for delivering aid, and argued for differential pricing. The basic message of the Commission's report was that the health situation in many developing countries is insufferable, that these countries do not have the resources to provide basic health care, that poverty and ill health contribute to social and global instability, and that, and I quote, globalization is on trial, and that therefore increased funding for healthcare in low-income countries must be found through both debt relief and increased aid. The I've commented already that the PRSPs were essentially that's to say the poverty reduction strategy papers were essentially a more user-friendly version of structural adjustment. They allowed the countries to draft their own structural adjustment program, but they still had to be approved by the IMF in accordance with the kind of policies of the Washington Consensus. This slide takes us through the details of the Treatment Action Campaign, which we've talked about a few times. The key dates are 1997, when South Africa passed a new law to authorise parallel importing, to source brand name drugs internationally through the cheapest supplier. In 1998, the 39 drug companies sued the South African government. There was continuing pressure from 98 through to 99 from the US government on the South African government. In 1999, ACT UP was giving Al Gore a bad time because in the context of the US presidential elections, and by September 1999, the US government was starting to back off. There was a huge petition collected through MSF, and in April 2001, the companies withdrew. And as I've said, April 2001, WHO had a meeting on differential pricing, but in December 2001, the WTO itself, trade ministers, reaffirmed the legitimacy of compulsory licensing. Okay, now another major issue which cuts across all these issues, this story, is the Millennium Summit in 2000 and the Millennium Development Goals, which undoubtedly represented some of the same drivers which were described so clearly in the Sachs report. The Millennium Development Goals include 8 goals and a number of subordinate sub-goals and indicators as listed on this slide. Another major event taking place during this time was the emergence of the Gates Foundation as a major player in development assistance for health. And at the time this slide was written, the Gates Foundation had a $35 billion endowment with an $800 million health program and was still increasing its capital endowment. The global public-private partnerships, GH or global health initiatives, have been a major feature from the late 1990s through to the early 2000s, and were in fact the main vehicles for the dramatic expansion in development assistance in the first decade of the present century. The International AIDS Vaccine Initiative from 1996, the Malaria Vaccine Initiative from 1999. These are just a few of these global health initiatives, which covered a wide range of product development, of product distribution, and research and policy. The Global Alliance for Vaccines and Immunisation, Gavi, became known as the Gavi Alliance, established in 2000, financed in large part by the Gates Foundation. We've mentioned the Global Fund to fight against AIDS, TB and malaria from 2002, the International Partnerships for Microbicides, etc., etc. Dr. Brundtland was followed in the Director General's chair by Dr. Lee Jong-hook from 2003 to 2006. Dr. Lee was a South Korean who had been a very strong polio man. Some of the issues which the WHO confronted during the period of Dr. Lee's tenure was the beginning of the SARS crisis, and Brundtland was involved in the early response to SARS. but Dr. Lee saw through the revision of the international health regs, which were finally adopted in 2005. The international health regs from 2005 represented a major step forward from the old sanitary regulations with which we started this presentation. The Dr. Lee made a personal statement with respect to AIDS HIV with the 3x5 campaign, and 5 million people on antiretrovirals within 3 years. He was also Director General during the time that the resolution on trade and health was adopted. This represented a significant step forward from the sort of conflict over the contradiction between TRIPS and the price of medicines to a more formal commitment in 2006 that WHO should assist member countries in assessing the health implications of trade agreements and in participating in the negotiation of trade agreements. And this resolution has been really very controversial. Indeed, the whole process of whether WHO has a role in providing this kind of policy advice has been very controversial. You may come across statements to the effect that WHO should restrict its activities to its so-called normative functions. That's to say, its functions in naming drugs or in collecting statistics, but not involved in policy advice as provided for in this resolution. On the other hand, the Framework Convention on Tobacco Control has been widely recognised as a victory for WHO. This was commenced by Dr. Brundtland, but was brought to fruition through Dr. Lee. Dr. Lee was also director when the Commission on Social Determinants of Health was established, and unfortunately, Dr. Lee died in office actually at the World Health Assembly in 2006, and was followed by Dr. Chan. On the right-hand side of this slide, I've got a few notes about Dr. Lee's career. He was involved in leprosy control in the South Pacific from 1984. He was involved in chronic disease management in WIPRO, the Western Pacific Regional Organization of WHO, in polio eradication in WIPRO, and was regarded as the vaccine czar in Geneva from 1994 to 1998. Dr. Chan was elected in 2006 and then re-elected in 2012. She was trained in medicine in Canada, worked for a long period in the Hong Kong Health Department in communicable disease control. She joined WHO in 2003, was elected in 2006 and then re-elected in 2012. Some of the key issues that Dr. Chan has had to confront during her period has been, first of all, the bird flu epidemics, including the H1N1 debates of 2007-2008. The follow-up of the Commission on Social Determinants of Health. Dr. Chan didn't see eye to eye entirely with the Commission on Social Determinants and Health, and has had to be pushed a little bit to continue to keep this on the agenda. She was in charge during the global financial crisis from 2007-2008, but it's not clear that WHO has really come to grips with the implications for population health of an unstable global financial regime, and the lack of action to make that financial regime a little more stable. One of Dr. Chan's main commitments has been WHO reform. WHO has been in dire straits for budgetary reasons, for increasingly bad situation budgetarily since the 1990s and early 2000s, as the proportion of its budget coming from mandatory assessed contributions has shrunk to only 25% to 20% of its total budget, leaving 75 to 80% coming from donors, that's to say particularly the rich countries or the large multilateral organisations like the World Bank and like Gates. It's and with, of course, the power which goes to those donors in determining how their money will be spent. And there's been a debate about whether, well, we'll come to this in a minute. Dr. Chan has helped to bring the debate in health policy back from vertical disease focused GHI-driven programs through to both primary healthcare, health system strengthening, with, in particular, has nailed her flag to the UHC mast, Universal Health Cover. WHO reform, which she has been driving since 2009, has got, broadly speaking, three main components: adequate funding, managing the regional distributed nature of this organisation, and addressing some of the staffing challenges. There's a fourth issue which has not been really properly addressed, which is the accountability of the members for what they are doing, the member states for what they are doing to WHO. And in particular, this applies to those states who have blocked any increase in assessed contributions, which would give WHO much more autonomy, which would give the World Health Assembly itself much more control over the organisation's budget. I think I've covered basically these points. One of the slogans from Dr. Chan has been adequate, predictable and flexible funding, but this will require increased assessed contributions. It will require their donors to convert their donations from closely tied, earmarked donations to untied donations. And what is perhaps worse is the increasing institutionalization of the process of negotiating funding with the funders, which represents the transfer of power over the organisation out of the World Health Assembly into the hands of the donors. Governance reform includes the problem of regionalisation, but and this has been tied to the issue of funding reform. It's linked to a couple of slogans which are worth understanding. One is alignment, which is saying that the structures and procedures of the regional offices should be aligned more closely to the policies and structures and objectives of the headquarters secretariat, and harmonisation, which is about making sure that the regions, the regional committees and the regional secretariats are all working along broadly the same lines. This is very much a project in transition. The problems of regionalism in WHO we've talked about before in relation to the history of PAHO, but the increasing financial distress that the organisation's in has meant that the regions are able to get funding for themselves through side deals with donors. Some of the regions have been, and are in that degree less tied to a coherent three-levelled organisation. Staffing reform has touched upon three broad issues: geographic sourcing, ensuring geographic balance with respect to different staff nationalities, while ensuring merit-based appointment. This has been a continuing challenge. staff mobility, which is about valuing specialist expertise in headquarters, as well as ensuring high quality staff in the country offices, and conditions of employment, which it would be a fairly common challenge in this case between the employee entitlements and the flexibility that management requires to manage a changing environment in a changing environment. I've said that member state accountability is the one thing which has been missing from Dr. Chan's WHO reform agenda. Member state accountability for their willingness to sacrifice population health to vested interests, for the lack of preparation of many member states prior to attending governing body meetings, for refusing to adequately fund WHO, and for failing to use the energies and forces of civil society to drive health development. WHO Watch is an example of civil society engagement in WHO reform. This is a project run by the People's Health Movement in association with a number of other global civil society groups such as Medicus Mundi International, Third World Network and Medico International. And it is seeking to change the dynamics of global health governance and the place of WHO through new information flows, new alliances, stronger links between what's happening at the global level and social movements operating at the local and national level. WHO Watch includes regional and global watching, actually attending governing body meetings, documenting, analysing, advocating, disseminating informed commentary about some of the global dimensions of current health issues, providing support for community-based policy dialogue, liaison with delegations to WHO, providing access to resource material regarding the agendas at governing body meetings, and maintaining an active website, which you're most welcome to visit. Okay, so some of the resources that we've used in this presentation are listed on this slide, and you're most welcome to follow them up. How should we plan to discuss this material? Maybe you might like to consider the implications for WHO of the ongoing connection between international health policy and trade relations. This has been a theme throughout the whole history that we've reviewed. Maybe we should discuss further the costs and benefits of WHO's regionalised and decentralised structure. The benefits both real, as presently achieved, and potential. How could you gain greater leverage from this regionalised structure? What about this idea of phases of global health care policy? Can we relate these phases to the prevailing geopolitics of the time? Maybe looking specifically at the policy strategies aiming to solve the problem of access to medicines. How have these different policy strategies been shaped by their geopolitical context? We've mentioned the different logics of global health: solidarity, charity, productivity, security, legitimacy. Can you see how these different logics are both expressed in and reflected in and influence particular policy issues? And finally, we could spend a bit more time talking about WHO's budget. Is it the case that it has been budget restricted because it is inefficient and ineffective, or is it ineffective and inefficient because it has been budget restricted? I'm very much looking forward to discussing these and other issues with you in more detail as soon as we get together.